Patricia Bergman.
Hello, Patricia. Well, welcome, everyone. My clock says 12 o'clock, and I want to honor your time and really appreciate all of you being with us right at noontime. So without further ado, let's get started. Let me just welcome everyone this afternoon to our Tuesday webinar series focused on the implementation of our Specialty Care Initiative Strategy Clusters. Today's webinar discussion is on increasing primary care provider capacity. This is Luisa Miranda, Senior Program Associate with the Technical Assistance Provider Team from Community Partners for the Specialty Care Initiative, and I will be facilitating today's program. For those of you who are with us for the first time, I just want to say that the approach that we have been taking is that we highlight various coalitions, reviewing the list of questions to provide a forum for sharing the best practices and learning so that we can have feedback and really have a chance to have sharing and really offer resources and networking among our coalitions. And I think this format, from all the feedback we've been getting, is that people really appreciate having this type of format. So before we continue, I just want to have you remember to please turn off your cell phones, mute your telephones if you have a mute button to prevent any outside disturbances during our discussion, and please do not place the call on hold as we may get your music if you have that option. Also, you can mute yourself if you are on the WebEx and you have access to the computer by highlighting your name and just hitting the little mute box, and that will mute your background as well. And then just to unmute, if you want to ask a question, just hit it again, or you can hit *6 as well. So those are our important reminders for everyone. So please be sure to handle that. So I would like to just take a quick roll call. As you remember, in order for us to really try to save some time, we ask when you sign in, if you can, in parentheses next to your name, list the coalition that you're with. So if you have that, that's very helpful for me. But if not, I'll have to check in with you to have you remind me who you're with. So we have our representatives from Valley Care Consortia. We have our Kern Coalition, and we have our Long Beach Coalition, Christine Susan. Christine, can you please tell me who you're with? Okay, she's on mute. Okay. We have our speaker from Santa Clara, Jorge De Luna.
Yes, and Joe Sexton is joining me as well.
And Joe. Hi, Jorge. Great. We have our San Francisco Coalition. We also have our evaluation team person, Lisa. And we have HCAP from Fresno. Vicki Wheeler with El Dorado, I believe. Is that correct?
Correct.
Okay. Sandra Dunn, who are you with, please, Sandra?
Both Christine and I are also with El Dorado, the Excel initiative.
Oh, great. Welcome. We have Marcelina. Marcelina, who are you with, please? May not be there at the moment. All right. And we have a representative from our Northern California, Christina, who is our grants manager. Welcome, Christina. And is there a question? Oh, I saw a hand go up. No? Okay. And did I miss anyone? Who's on the line with us who's just tuning in on the telephone? Can you please tell me your name and the coalition you're representing today? Anyone on the phone today? No? Okay, great.
This is Hallie Hammer from San Francisco General Hospital, but I'm not representing a coalition.
Okay, great. Welcome, Holly. Anyone else? All right, well, thank you. Thank you all for being with us today. So we will get started with our program. As I mentioned, our discussion today is on increasing primary care provider capacity. And if you were on our call last month, you recall that our coalition from LAC-USC spoke about their approach to increasing primary care provider capacity using the mini fellowship model. Today's program will feature Jorge de Luna, Vice President of Clinical Activities, and Joe Sexton, Director of Quality and Population Health with Community Health Partnership, which is the lead agency for their coalition called the Santa Clara County Specialty Care Access Collaborative. Welcome, Joe and Jorge, and thank you so much for being with us today to share the work that your coalition has been doing in this particular cluster.
Thank you, Lisa, and thanks to all of you for attending today's meeting. Should we go ahead and get started, Lisa?
Yes, I was just going to say, why don't we get started with our first question, Jorge? Please provide a background of your coalition and the group's focus prior to the Specialty Care Initiative.
Well, in some ways, I think that we've had a longer time working on this issue. This dates back to about 2004 and 2005 when Community Health Partnership and Santa Clara Valley Health and Hospital System received a grant to work together on a specialty referral system, an electronic specialty care referral system. And that was rolled out in about 2007. However, when you roll out an electronic system, not all of the problems are solved, and in fact, new ones come up. And that is exactly what we experienced with 2 years ago, or actually 3 years ago when Valley Express was rolled out. We found out that there were many, many gaps in process, in systems, electronic systems, and also in communications between the community health centers and the hospital system, specialty care. So then we participated in the Kaiser Permanente planning process to identify what we wanted to work on in the implementation process. And what we really found out was that we wanted to focus on the gaps, like in communication, on the gaps in systems that still were prevalent. A lot of electronic systems were not working properly. And also in increasing the communication patterns between primary care providers and specialists. So those are some of the areas that we wanted to focus on. Joe's there, and by the way, Joe is here sitting with me, and he also has a lot of knowledge about this because Joe had worked on this project from the community health center perspective 2 years ago, or not 2 years, but actually 3 years ago and more, when they were rolling out the electronic referral system. So he has a lot of really good information as well to share. And so we're going to be taking turns in talking, and there are some areas that I have some understanding about, and then others that Joe knows a lot better than I do. So the background of our coalition, we've had a very, very good relationship with our county hospital. And I think that we really capitalized on that. They are a tremendous resource for the safety net in Santa Clara County. And we also share patients. We like to emphasize the fact that we share patients and emphasize that when you improve systems and processes for the hospital, you're also doing it for the community health centers and vice versa. So in the end, we really hope to improve access and decrease demand to specialty care through our coalition, which is represented by many different groups of people at community health centers and county clinics and hospitals. So we have, for example, included people from the IS department. We've included people from utilization management, scheduling, primary care providers from community health centers and the clinics at the county hospital, as well as specialists. And then, of course, the consortium also is well represented. So we have a fairly large team of multidisciplinary team that looks at this problem of access to specialty care from many different perspectives. And so that's been really beneficial to us.
And I think just to highlight the point Jorge has made is that, the partnership and the hospital have always had a strong collaborative relationship. And what the grant allowed the collaborative partnership to do was to really move forward and begin to make, I think, substantial changes just to improve the responsiveness of our electronic referral process, which we call Valley Express, and also look at ways to improve the actual communication between the primary care provider and the specialist. And that was what we began to formulate in the year 2009 through the grant from Kaiser. And I think we have had some successes and we've had some challenges as well. We've been able to make some substantial changes and improvements to the electronic referral system.
Right. I understand, Joe, and I know we're going to be getting to those. So let's just save those for just a minute. Is that okay?
Yep.
Okay, great. I would love to hear about those, but let's just go back to, with that wonderful base that you set to really start with the electronic referral system, what approach have you been using to increase your primary care provider capacity? What are some of the specifics that you've done in this particular cluster? Excuse me.
Okay, so I can speak to that a little bit, and Joe, if you can elaborate also. So our approach has been to focus more on increasing communication between PCPs and specialists, but also between the community health centers and the Santa Clara Valley Medical Center and their Valley Specialty Care clinic, basically. And what I mean by improving communication is not just the regular talking, but also the information exchange that goes on between all different organizations here in Santa Clara County. So through our approach, what we have hoped to do is to continuously increase our understanding of where the needs for specialty care are, and to also identify the gaps that exist in specialty care referral system and in the utilization process. Basically, we want to understand these better so that we can balance the equation between increasing demand, and actually between decreasing demand and increasing access to specialty care. In the end, what we really hope to do is to implement and build a system and implement and build system changes that are sustainable over time. So whatever changes we implement as we're going through this process will be there many years from now. And also, as ValleyMed makes changes to their own internal processes, those changes that we made before will just be improved. They will be there. They will get better. So that's what we see for our approach, is to change the system, improve a system that will be there in the long run. It basically embedded into the system that Valley, the county hospital has. So that when we are done with our collaborative, not that we're going to pull away from our collaborative, but when we're done with this process, the changes that we made will always be part of the system in the process.
Mm-hmm. Are there any questions for Jorge regarding this approach? How often does your coalition meet, Jorge?
We meet, is it monthly?
The two liaisons, the main lead from the partnership and the main lead from Valley Medical Center meet monthly. The entire committee meets every other month.
So you have meetings in between the big group so that you can maintain that communication.
Yeah, just to provide follow-up on projects.
Great.
Also to focus our meetings with the overall group better, so that we can, tackle those issues that we brought up or that came up in previous meetings.
Great. Okay, any questions or comments? All right. So can you tell us more about the primary care provider Meet the Specialist luncheons? I know you've used that as one approach to increasing your primary care capacity, and I know you've offered continuing medical education. So can you just tell us more about your program, Jorge and Joe?
Yeah, I think Joe's going to take that one,
Okay,
and I'll help out.
great.
Meeting the specialist or, the luncheons with the specialist has actually been one of our major successes. And we've been able to build communication between the specialist and our primary care physicians. As a partnership, we have QI meetings monthly. We carry out peer meetings, and we have a peer meeting with the medical directors from 11 different clinic organizations in Santa Clara County. So we have a natural venue to bring our medical directors together from the community clinics. Our medical director at the partnership is also on staff at Valley Medical Center. So she has a solid relationship with physicians, specialists at the acute hospital, and obviously we have a direct line to our physicians at the community clinic. Therefore, we've brought them together and we've created the opportunity, which we call Meet the Specialist, during which the specialty care providers educate the referring primary care providers on the referral guidelines. And they have also made specific presentations on disease processes during that medical director meeting we have once a month. Over the past fall and winter, we held 2 sessions, and the presentations really helped to decrease the isolation between the primary care provider and the specialist, and it's an opportunity to build a knowledge-sharing relationship. The primary care provider can continue to learn about what they can do before referring the patient to a specialist. Recently, just this past February, we had 30 people attend the ophthalmology session, and a number of other physicians from our clinic participated through the teleconference. And again, during these luncheons, the specialist and the primary care provider do get to review the guidelines. And, the primary care provider also has the opportunity to provide feedback on whether or not these referral guidelines are meeting their needs based on the patient population. And the specialist, has the forum to talk about, what is an inappropriate referral, what's an inappropriate referral, and they've actually been able to bring actual examples. So it's kind of a way of lowering the barrier between those two populations, and it's been extremely popular on both ends, both for the primary care provider and the specialist. And hopefully, over the summer, we'll continue to move forward. We still like to bring orthopedics and general surgery to the table as well.
So can you tell us how you recruited the specialists that are the speakers for your luncheons?
Well, one of the ways we do it is, number one, we have that relationship between the partnership's medical director, who's on staff at Valley Medical Center, and also sits on the Specialty Care Initiative Committee. When we formed the committee a couple of years ago, we invited representation from 4 or 5 different specialty areas. And by having a couple of those specialists participate on a regular basis, so by having specialists at our committee when available, it's helped us begin that conversation and bring them into kind of the brainstorming on how to improve communication. So it's really been through the existing relationship that we have formed over just the history of our collaboration. There are challenges. Certainly there are certain specialists that don't always have, or specialty departments that don't always have the availability to attend our collaborative meetings. So, one option too is perhaps reaching out to specialists that are newer to the system and want to also use it as an opportunity to promote their service or introduce themselves.
Right. Any questions about recruiting specialists from our participants today?
Could I say something about also the part, Lisa, in regards to our luncheons?
Mm-hmm.
I think that it's been really good for us. And actually, at the beginning of the collaborative, we had a lot of resistance from our PCPs in regards to mini residencies. They just felt like, okay, we have so much to do already. We cannot practically expand our scope of practice to include every specialty out there. And so they were feeling that, mini residencies were not an option for them. So we came up with the best next best thing, which was the luncheon with the specialist. And I think that one of the lessons learned from having done that is that we really have created something that's resulted in a lot of interest on the part of the primary care providers to learn more about specialty care. They have identified knowledge and skill gaps, and they've had the opportunity to ask a lot of questions of the specialists. And so, we couldn't do a mini residency, but we could do this next thing, and it's just amazing to me how well welcome they are. They really like having the specialists out here. I can personally, my perception is that. Are we okay? Is everybody able to hear?
It sounds like someone put their phone on hold, and we're getting some of that music. Can you please put your phone on mute or mute your name? Because we are getting some feedback here. I apologize, Jorge.
No, that's okay. I just want to make sure everybody's able to listen.
Yes, I know.
So, just having that resource, bringing the specialists on board to talk to the PCPs has really opened the lines of communication as well. You can see that when the PCPs are able to put a name to a face, they feel a lot more comfortable contacting these specialists. It's a way of forming a relationship that they didn't have before. And it's just amazing. Like every time that not every time, we've had 2 of these so far, and each time it's like we could have had 1 more hour at least, because the PCPs are very interested in what the specialist has to share with them, and they have a lot of questions. And I think one nice outcome of these is that the specialists have also been very convincing in telling the PCPs, hey, there's a lot of stuff that you can do that you may feel reservations about doing, but you're very capable of doing. And, the neurologist, for example, was talking to the PCPs about, just headaches and what he does when he sees patients that come constantly to see him about headaches. And some of these things that came up were, in fact, new to a lot of the PCPs. And they were like, wow, I never thought about doing that. So these have been very, very beneficial. And recently, we had a medical directors retreat. And to my surprise, they were interested in having more of these talks. They asked for the ones that we haven't completed yet, the orthopedics and general surgery. But in addition to that, they're interested in other specialties. So definitely we want to continue to bring the specialists to present for the PCPs. And I hope that orthopedics and general surgery, we will have done those 2 by the fall, and then, of course, continue to provide that resource for the PCPs.
Great. Well, I know that you have offered CMEs, Jorge. Can you just briefly tell us, did you partner with any other group? Because I know some other coalitions were under the umbrella of another hospital to really take advantage of the program that they offered for CMEs. But is that something that you had to do, or can you just tell us a little bit more about your credit program for those sessions?
We're actually certified to provide CME. Community Health Partnership, we have a certification to provide CMEs, and we've had that for, I think, I want to say 3 years. We just had our recertification last fall in October, and we have our certification is good for 4 more years.
Great.
We find that very valuable in not just for the meeting with the specialist luncheon series, but for other meetings when we can provide CMEs for our doctors and doctors from the community. You know, that's a great incentive for them to come and participate. Oftentimes, we have a challenge because we can't provide CMEs if the majority of the audience is not sufficient. In this case, with the luncheon series, the vast majority of the participants are doctors. So we're very, it's good that we're able to offer CMEs.
Great.
And that has been a great incentive for participation. In fact, even the specialists that are presenting, one of their questions usually, I think they use it to make the decision as to whether or not to present is, can you offer CMEs? And when we say yes, we can do that, they're, I think, more likely to say yes.
Yes, terrific. Are there any questions regarding the CME program or recruitment of specialists from our participants? It's a very thorough job of explaining that, Jorge and Joe. Just a quick reminder, everyone, if you have your cell phones on, please turn them off. We are getting some feedback from someone that's out there, so it will affect our recording for today. As you know, we do record these sessions and post them to CCV, so just a friendly reminder. Thank you. All right, I think you've already talked about this, how your luncheons have impacted the development for the revision of your guidelines. So is there anything else you want to add to that? I think you pretty well covered that, Joe. Anything else?
No, I think you're correct. We have covered that.
I think we've covered that. Any questions from our participants on the line today so far? Okay. So why don't we start just expanding now more about your accomplishments. I know you've done a lot with building the relationships and really continuing the work that you started with your e-referral system. You want to just expand a little bit more on that today?
Okay. So I have a list, and Joe, please feel free to throw some others that I didn't think about or that we didn't list here. So one of the biggest accomplishments for us is actually being able to produce reports and to analyze the information in regards to referrals. We still have a lot of work to do in terms of outcomes, balancing that equation between reducing demand and increasing access.
Mm-hmm.
There's still more work to be done, but I think that having these reports really help us to work towards that goal. Another accomplishment is actually enabling the clinics to access their own specialty care reports. And there's some really, really valuable information in the reporting that they get. They can see the disposition of their patients' consultations, whether or not it happened, how many they've had, what physician they saw. A lot of really good information that they have access to. It's an automated process that goes out to the clinics, and they just go in and pull the information, the reports that they need. So another accomplishment has been our specialty referral system user group. That has been really, really popular. We host it, and people show up. Probably anywhere between 20 and 30 people from the different clinics come to these meetings. And what they come for is two different things. One is they come to learn more about the system and how things are working. But they're also bringing us problems that they encounter. And so from those problems, we take them to the collaborative and try and find ways to resolve them. So it's been a very enriching group for the collaborative, is to learn what barriers people are coming against, and also to listen to them and hear what is working for them. Some of the outcomes, one of the outcomes of that group is in what we call the MION. MION means basically the specialist is a dynamic online system that primary care providers at the clinics can access readily, and it gives them information, the latest information as far as who is the specialist in charge at the hospital. Who can they call right now that will be there? So it gives them their phone number, their fax number, their pager, and they can contact the specialist. If they have a question about whether or not they should be referring someone, they can easily call a specialist and say, hey, I have a patient here, and I'm wondering if I should refer this patient to you. What do you think? They can do that very easily because they know, because this is a dynamic list, meaning that as the specialists are coming into work and leaving work, the system is updated. So they always have up-to-the-minute information in regards to the specialists that are working. And so that creates open communications between PCPs and specialists. Another access that we provided for the clinics that is very helpful is access to the scheduling system. They can see if the patients were able to schedule a visit, whether or not the visit was canceled, if they did see someone, what's the name of the specialist that saw their patient, and can they be looking for consultation notes, and if they saw a patient, if the specialist saw a patient, why don't they have consult notes? At least they know that they need to look into that. So the access to consult notes has been something that we've been working as well on, and that is an accomplishment. We made progress. We still have some barriers and some challenges to overcome. But part of the reason why is that the notes at the specialty clinics are produced by different vendors and systems, and we're trying to bring them all together so that, whoever's putting together the consult notes makes them accessible to the PCPs. The luncheon with the specialist, I think, has been a tremendous success for us, an accomplishment that, it seems like easy to do, and it actually it just helps the PCPs tremendously, and I think the specialists as well, because they are able to talk to each other and learn from each other, and so that's been really a great success. I wish it's also been a little bit of a challenge because we, for example, have not been able to schedule the ortho and general surgery luncheons, but we're still working on it, and there are some opportunities there for them to happen in the summer. But it's been a little challenging, but they're just so valuable, I believe. So the other challenge is that not challenge, but actually the other accomplishment that we've had is that we have been able to bring a very broad system of collaboration together. So we have people from IS, and I think I mentioned this earlier. We have people from utilization management, from scheduling, the specialists, the PCPs, the consortium. So we all come together and talk about how do we make things better, how do we create better access for patients, and how do we stop, any potential waste that occurs when we make inappropriate referrals. So we have a broad base of collaboration, and that's been, I think, in itself a great accomplishment.
Well, it sounds like you've accomplished a lot, Jorge. That's a long list of accomplishments. Congratulations.
And I would just like to mention one more thing, and probably the other collaborators are aware of this, but, through the initial needs assessment, we identified those 5 specialty areas where we needed to work with those specialty areas and the PCC in helping to, reduce demand. And we have now been able to really look at their average wait time and other performance measures through working with the Valley Medical Center and their scheduling system. And beyond that, we're now just starting to look at if we can even drill down further and find specific wait times for actual procedures. Instead of just looking at the specialty, like, let's say, neurology, we want to know if we can learn what specific procedures in that specialty department where there are real bottlenecks occurring.
Great. Any comments or questions regarding Joe's comment? Sounds like you've really gone, pretty far with that whole measure in terms of gathering data. Can you just briefly share how the wait time has changed, Joe? Do you have that information yet?
Well, we have the time for probably the last
quarter
month, because that's when we started submitting to Kaiser.
Okay.
And we have seen. Now, I don't have the exact data on me, but we have seen some decrease in some specialty areas. It can tend to fluctuate depending on what the internal department is experiencing.
Yes.
If a specialist has taken a sabbatical or one is out on leave, we will see those wait times tend to spike.
Good point.
And that is an experience we're having right now with one of the departments.
I want to mention, and kind of related to that, but also giving the clinics information and reports. One experience that we had recently is that one of the clinics called us and said, "We think we're making way too many referrals. We want to know what the other clinics' referrals are like, because we're looking at some of our data and we're thinking that we're overutilizing specialty referrals." And so that in itself, I think, to us, the fact that a clinic has come to us and say that, it's good. It validates the work and the information that they're receiving. It tells me that the clinics are looking at what they're doing in a more, they're looking at themselves and just examining themselves and their specialty referral rates, and they're wondering, are we overutilizing these resources?
Great.
So I think that we started to work with that clinic, and I think that the outcome is going to be that some referrals will decrease as a result of these process. Who knows? Maybe they won't change, but I'm hoping and I'm thinking that they will.
So it's just taking a look at their own self-assessment and really reaching out and asking for assistance. That's great. So you've touched a little bit on your challenges. Are there any other challenges you want to share or expand upon?
Well, I think that one of the challenges that we've had, I think it's that there are some members of the collaborative that are kind of reaching a certain level of fatigue where, maybe they're not participating at the same level that they were participating in the past.
Mm-hmm.
Other challenge is that we've had some turnover here and also at other participants in the collaborative. For example, the physician champion that was taking over the reviewing of the referral guidelines retired, and ever since he left, we have not been able to get another person to kind of champion that the referral guidelines review. On the other hand, I think that we have a good opportunity. Unfortunately, Christine Tyler, our counterpart at Valley, the hospital system, is moving on to another job within the hospital. And I think that, she was really, really great for these collaboratives because she knows community health centers, she knows consortium, and she knows the hospital system. But she's been really great for us. I think that we do have an opportunity with a new person taking over to kind of like bring back some of the participants that are kind of moving away and just kind of revive the whole process and look at the referral guidelines once again and see how we can change that, improve them, and review them and update them. So those are some of the challenges I think that we've had.
Yes. I think you've raised a good one there in terms of fatigue or turnover or just, somebody retiring can really affect the momentum. Anyone out there today can relate to some of the challenges that this coalition has faced and how you might have handled that particular challenge? No comments or questions or sharing of experience in that area?
Hi, Louisa. This is Joni.
Yes.
The challenge that he'd mentioned about people becoming less involved, during our planning phase, we did have a clinic that had supported us with a letter of support, and then they had some massive layoffs of clinic administrators, and they haven't participated since. And it became a topic of one of our meetings, and whereas we tried to reach out and bring them back in, they're just, I'm assuming, so caught up in their own issues that we have decided that one of the very active clinics has 2 sites, and instead of involving their one site, that we would open it up to their second site. So sort of replacing one. Unfortunately, it does mean that there's a whole clinic partner that won't be involved for a while, but we feel that maybe next year talking to them again when things calm down might be a better approach for us.
Great, Joni. Thank you for sharing that. Anyone else? All right, let's move to our next question. So what are your next steps or your plans for increasing primary care provider capacity? I know you have planned general surgery and ortho, is that correct?
Correct.
Okay, anything else?
I think that bringing our medical directors together to really identify their knowledge and skill gaps is the next step that we kind of started through their recent retreat that they had. They really started working on that already. But I think so identifying those skills and knowledge gaps is important. We will continue the luncheon series and expand on them. And also very important for us, I think, to identify a champion to work on referral guidelines again. Any others still?
No, I mean, we continue to tweak the system. There were a few departments, specialty departments, that were not on the electronic referral system. Physical therapy has just been brought on, and we're doing implementation planning to add diagnostic imaging and ultrasound. And we're also working to incorporate a mechanism on our electronic referral system for different fields to add additional information needed for referral, such as like weight consideration if someone needs a treadmill. I guess we're drilling down to a little bit more specific data in our request for referral.
Okay, great. Any questions or comments? All right, so given all that you've accomplished and the challenges that you face, what advice would you give to your fellow Specialty Care Initiative colleagues about increasing primary care provider capacity?
I think that my perception about the luncheon with the specialist, I keep going back to that because I think that we had that initial resistance. But basically, if you build something for the physicians and if you do it right, I think they will come to the table and participate. I also think that we've had a really good opportunity with our CME certification to not only talk to our physicians about, hey, we can provide CMEs, but also addressing their own knowledge and skill gaps, what they want to learn about and what they want to be looking at. You have to do something that is interesting to the PCPs and then bring the specialist, and I think that will happen.
I also think one of the things we were able to utilize were existing ad hoc groups in the internal system, such as there was a hospital discharge group that was pre-existing that did look at, access issues, and that's made up of, physicians from the acute care center. So we brought them into our committee. And we also brought in, the user group among our clinics on on the electronic referral system, and I know I kind of always go back to the electronic referral system, but that user group, which is made up of clinic staff, including MDs, has been so helpful in providing feedback that gave us really precise challenges they were having in terms of communication about patient care and continuity of care between the PCP visit and the specialty visit, and also long wait time. So just involving any existing groups that may be working on more specific areas into the broader issues has been really helpful.
Great. Any comments or questions regarding this advice? So it's really building upon what you've already developed and on those strong relationships that will only expand and grow stronger with that ongoing communication link that you've developed so well. Well, you did touch on this earlier, Jorge, about sustainability. So how is your coalition approaching sustainability for your efforts?
I did talk about it earlier, and I think that's really important to us. We want to, what we do through this specialty care initiative, we want to make sure that it's long-lasting. And I think what we try to do is to really embed all of these system and process changes into the system of care, so that they are there, years from now. They'll be different in a few years, hopefully better, not worse. But basically, we really try to the system, but we still have to focus a little bit more on the outcome. And I think that these changes that we're making are really helping us to do that. But yes, I think what we need to do is to focus on system changes that are long-lasting and that we can count on years from now when, we don't anticipate that we will not be working with the specialty care clinics in the future. I know that we will be working closely with them in our clinics as well. But we want to make sure that whatever changes we make are embedded into their system, because that's a great resource for our community. That's an amazing resource that we have for the safety net here in Santa Clara County. And if the changes that we make are not in the system, then they're going to go away, and we don't want that to happen.
So
Joe, do you have anything else?
No, I think that you've covered it all.
So what you're saying is it becomes a way of doing business that becomes just the way people work, and they're part of the process of work and the workflow. And they get changed along the way as needed if you continue that communication network that you've started and that you've continued to build upon.
Right.
Is there anything that our participants today would want to add to their approach to sustainability, or thoughts that you might have about how you're approaching sustainability, if it's related or different in some way? No comments?
Everybody's quiet today.
Well, you're doing such a good job of explaining the work that you've done, your best practices, and your challenges and accomplishments. So now it's your turn, gentlemen. What question would you like to ask your Specialty Care Initiative colleagues today?
I think one of the questions that I have is, how much have you focused on existing systems? Because many times I feel like, we're doing too much of that and not enough of balancing the equation between decreasing demand and increasing access. But banning, bringing more specialists, what changes can we do? We thought it was very appropriate to make system changes, and I wonder how much and what systems all of you are focusing on.
Okay. Who would like to respond?
This is Sandra with El Dorado County. I guess I would ask the question, when you use those terms systems, can you define what you mean by that?
Okay. So what I mean by that is the system of care in the county, how we relate from organization to organization. And I also mean information exchange system and the system of communication that we use to exchange information between specialists and primary care providers. In the system of referrals that exist, so in some places I think, referrals are manual. That is the system of referrals. In our case, we have an electronic system, but with many gaps that we continue to work on and improve upon. So that's what I'm referring to. I don't know. I hope that's helpful.
That's helpful. The approach we've taken is to start with a manual sort of definition, sort of what are the needs and requirements of both the primary care as well as the specialist, and then create with their combined engagement, as well as some of the ancillary staff, clinic staff, which was mentioned by another caller earlier, so that we define the tools and agreement terms amongst those various parties that helps to simplify and standardize the expectations amongst all the participants. So that's a key right there to begin with. Then we clarify operationally who are going to be the participants and how they will engage one another, and then we implement that using standardized work processes, and we monitor it. We have taken in the past some of those manual processes and actually put them into and are using shared technology between the various agency sites. But we haven't, we didn't sort of jump into the technology right from the get-go. That was added after we had made the definitions and the sort of infrastructure commitments amongst the parties before we then translated that into the technology.
I actually see a lot of similarities in your approach, Sandra. I appreciate what you said.
Thank you, Sandra. Anyone else?
This is Joni. With our approach, we did similar to what I think, Joe, you guys said you did, was created MOUs with the clinics that clearly define what we want to accomplish with the specialty care training sessions, and then we actually asked the folks to identify 2 or 3 physicians so that we could create a listserv. And we have our a neurology education session coming up for the 24th, next Monday. And the problem that we have is, even though we've done that identification, one clinic that's identified 3 folks has identified one particular physician to be the neurologist clinic champion, and yet he's unavailable for Monday. So we may risk not having that clinic participating. So I've just started making telephone calls, and just on 3 different doctors, their best available times just aren't coordinating. How did you guys get around getting the bulk of your people in the room at the same time to make it worthwhile for the specialists to come and do the training sessions?
Yeah, it's because of our peer group. We have the medical directors meeting on a monthly basis.
Mm-hmm.
And so we use that forum as an opportunity to bring the specialists. The doctors are already used to coming.
Gotcha.
They put that in their schedule. And so I think that makes the biggest difference for us.
You know what? Thank you. You just gave me an idea, because I know those doctors go to the CCALAC on a regular basis. Maybe I could contact them and see if we could piggyback on their meeting.
That's a great idea.
Great. Very helpful. Good point, Jorge. as you've done so well to demonstrate, you keep building on what's already in place and then expanding it and continuing to expand those relationships and taking advantage of what's already in place. So that's a really key point. Any other comments or questions?
I have to say, it's also very helpful to have our chief medical officer. She knows all of the medical directors at the county clinics, the community health centers, and she also knows a lot of specialists because she also works part-time at the hospital. And, you know, basically, you just don't say no to our chief medical officer. She's great, and she's really good at building relationships and convincing, you know, just creating an atmosphere for collaboration. I think that's been really helpful.
So she really sells your program, Jorge.
She really does.
That's great. Okay, any other questions or comments? All right, well, we are now at the end of our session. If there's no other comments or questions regarding today's program, I would like to invite you to continue the conversation with Jorge and Joe. If you are interested, if you have any other further questions, their contact information, again, at the Community Health Partnership, who is the lead agency for their collaborative. Jorge's phone number is area code 408-556-6605, extension 202. And Joe Sexton's contact phone number is area code 408-556-6605, extension 208. So same main number, two different extensions. Any other comments or questions before we close? Just a reminder to please be sure to fill out the brief survey at the end of our program today. We really welcome and appreciate the feedback for our sessions, and thank you so much, everyone, for taking time to be with us today, and thank you especially Jorge and Joe for sharing all the work that you have done. We really appreciate you being with us, and thank you for your time, and congratulations on all the work that you've done.
You're very welcome. We're happy to do it.
Thank you. Okay, goodbye, everyone. Have a great afternoon.
You too, Lisa.
Thank you.